Yes.
I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you.
We usually stand for this, Leslie.
Thank you. I'm going to be Rotary Day next week, by the way. Are you coming to the meeting? How is it you're the only person that can make me blush? How is that?
He does have that way, doesn't he?
Yeah,
And you really are.
I know.
Seeing no public other than, I think I see a drape on the top of people's foreheads. There you go. We'll get to you, I'm sure. So we'll move on to the consent agenda items. Any questions? If not,
I'll move we approve the consent agenda as presented.
Second.
moved and seconded, those in favor?
Aye.
Aye. Motion carried.
Thank you.
Okay, March financial report.
Okay.
But can you space bar, whatever works.
Gosh, I'm so glad that there's sunshine and it's spring. Okay, so here is March. February was really tough at 319. March bounced back at 382, so it's like January. These are still kind of slow months for us, but they're better, certainly better. Notice there is a decline year over year of 16%, and that we are certainly feeling that. Our average this year now is 389 a month, so we were pretty close to average for this month. Down under ancillaries, which is becoming a more and more critical piece of the puzzle, lab had a good month, and radiology, they both bounced, they had a significant increase from the prior month. Both are somewhat down year over year. Home health is typically up and down. It's a little down. It's not really out of range, I don't believe. Rehab is our only department with an increase in this column year over year. Although health clinic is staying absolutely steady, which is pretty bizarre, at 0. Like to see that grow some, but that still is quite a few patients overall. Not bad. Okay. Our monthly gross patient charges for the month. So the current year is in orange, and the year right behind it is this blue-gray. So overall, for the year, we had a good month in charges. It was 2.73 million. Our average for this year is 2.5 million. So we are experiencing a 7% increase in gross patient charges year over year. Our collections on AR, the current month is March. Now, usually I can get a month ahead, but this meeting is so early in the month that I don't have April deposits yet. I'm still missing a day, so I didn't report that. So we did look at this last month. This is a huge month in collections. The collections for the month were 2.4 million, well above our monthly average of 1.78 million. Okay, so we're seeing we just saw we have an increase in our gross charges of 7%. And yet we have a 2% decrease in our collections. So that means our cash is going down. This has a lot to do with the fact that our days in AR is too high, and it has to do with the fact that our contractuals are growing up faster than our revenue. And there's a lot of reasons for that. The biggest one, of course, is we raise prices. When we raise our prices, we do not increase our revenue by that much, because the contractual, the amount that is deducted, especially between what we charge and what Medicare pays us, grows. So that's part of that. I think another piece of it is going to be cured by great revenue cycle management, because I think that they're more complete on occasion. We want this never ever to happen naturally, but if we fail to get a pre-authorization for a procedure and we don't get it, we don't get paid. So we definitely think we're looking at that and other things as ways to, and to make sure that that our contractuals are as low as they can be. And Lisa is doing an awesome job. And here's our days in AR coming down. Currently, it is 71 days. So this is excellent, and I expect that trend to continue. Our days cash on hand, this is our current year here in blue. It's gone up and down. Right now, it's at 107. So remember, this is kind of all about construction spending. So the bond draw comes in April. It's going to be $1.7 million, so that 107 becomes 133, which is a much more comfortable place to be.
So if we didn't pay it right, that would go way up, right?
Way up, way up. It's all a George's fault.
At least by 10 or 12 bucks.
But, so yes, this is a bond draw, but I'm also expecting that good revenue cycle management is going to turn some of our AR into cash. And as we get closer to that place where we're watching that, I mean, it's been so high, we've kind of been able to sort of ignore it. Now, I'm glad that we're not. I'll see it go up. Okay, so our P&L for the month, we did have a profit of $94,000 for the month. Our revenue was above budget. Our expenses were above budget, but then, and that's not too bad. So anyway, $94,000 for the month. Year to date now, we've got a loss of $421,000. Looking at the year to date, you see that we have a $600,000 overage on revenue. Now, if you took Wellness Center out of this equation, we would be under budget by $300,000. So Wellness Center's having $1 million positive impact on revenue. Expenses, you see here, we are over budget by $1.2 million. Well, if you take Wellness Center out of that, we'd only be over by $400,000. And I just want to keep reminding you, because when I look at this number, I kind of freak out, that this $600,000 that we are behind budget is really a combination of lack of revenue and some overage on expenses. It's not just one or the other. It's not like expenses out of control. And I think that's important. So anyway, we are $600,000 behind budget. My sense is that April is going to be a fairly good month. We've had a lot of surgery, we had targeted surgery, and we've had pretty good census. So I'm thinking it's going to be okay, but no promises from me.
Are we up to speed on billing on the wellness center? I mean, do they pay evenly, or do you get that big lump?
They pay us whether we bill or not.
Oh, they do?
Yeah, I mean, so they kind of slap your hand because they need that information. We need to be billing, and we are billing. We did get behind, but we're either caught up or very close to being caught up. They need the information to do reporting and everything they do, so we're required to do our billing. But it doesn't have any impact on the GOBI funds we get on the state allocation, which is 99% of the money we get. So it's hard for me not to put that at the bottom of my priority list because I know it's not going to impact my cash flow. Okay. So for the balance sheet, really what happened here, as we have been seeing the cycle, as we pay for our construction spending without borrowing, the cash goes down a bit, and the assets go up. Next month, the cash will go up and the debt will go up. AR is down. Where's AR? Patient AR has come down. That's a very good thing. Which is why the days in AR came down. So that's the hospital. Any other questions? So we'll go on and talk about Goose Lake. Starting with Lakeview Gardens.
Is it helpful that you're getting the financial information in advance so that this is not all new? We're just trying to highlight some of the reasons and justification. So I don't want anybody to think that just because you don't have a lot of questions, it's because you haven't seen it. But we've sent it out and given you time to read it.
She asked all her questions at the finance meeting.
No, but we get all the detail, and that's.
Do I have a reputation?
Right, you get a lot more detail than I show here.
A little bit.
And I guess that, of course, you could call me or email me if you have any questions anytime, and some of you do. Can I use the Lake Health District email for all of you now? I know not Judy, but everyone else is getting, so I could just send it to that one and not, I was just a little worried, so.
No,
No, okay, so
I'm
Chuck and
going
Judy.
back to the old system.
You're
I
going
need-
to the old
I need
one.
this.
Yay.
Gerald?
I was gonna say, why aren't we on the Lake Health District? She's not sending emails to but anyway.
Because
What
I've
do
got
you
a
got?
lot of people telling me that they're not getting the Lake Health District, so I'm copying them.
My,
Well, now-
my problem is that if I download it, which it requires me to do,
Mhm.
it's gonna go on my computer anyway, so why not just use what I've got?
And our website people are trying to look into that, but it's not so much how it's uploaded, it's the 9 times out of 10, it's the device. If you're using a laptop or a mini laptop, a phone, a tablet, it's the system, the operating system on your device. It requires a download, so unless you're using an actual computer, we can set it to pop up, but that's it.
That's-
Well, I got on the secure side. I mean, you sent me that link, and I got on there.
But we're talking emails, or if you look
Yeah,
at it
and
from
but
the
I
link,
think I'm
yeah.
missing stuff.
That sounds like a good IT answer, blame the computer.
Hey, that's not me, that's coming from them.
Well, Jen, mine works fine.
Okay.
That's because he's a techo genius. And the rest of us aren't. He's a genius.
Alrighty, so I'll just keep sending them to both places so you guys make sure you get it.
Please.
Thank you.
I just didn't want to annoy you and then you tell me that it was annoying. So. All right, so Lakeview Gardens. March is here at 562, so they also have experienced a bit of a dip and it's coming back up again, and that's great. So year over year, a 5% increase. Monthly revenue this current year is in gray, and you see again it's gone up with our patient count and back down, and I hope it's on an upward trend now. The revenue for the month was $164,000, which is below our monthly average of $189,000. The Lakeview Gardens profit and loss, March is here at 164. We did lose $67,000. We did spend about $20,000 on new stuff for the cottages that we can't capitalize.
I saw that.
So that's a big chunk of cash that, you know, contributed to this loss. But also, we're still really struggling with temp labor. It's still crazy high. And we, you know, of course, with the lower census, we know that we need to be at about 650 patient days a month to make a profit, which is about 22 patients. So we're there now. That's a good thing. And we've kind of been there for several days, so I'm hopeful about that it'll stay on the high side here for us. So year to date, we've got a loss of $137,000 compared to last year's loss of $152,000. So we're pretty close to where we typically run. And for Lakeview Gardens balance sheet, the only real change you see is that as they lose money, the debt that is owed to Lake Health will, it goes and declines as their profits. Okay. Goose Lake Medical Services. This is their monthly revenue for the month. It was at $62,000. It's quite above their average of $53,000.
Oh, is that February?
Oh, it is February.
Yeah.
Yeah.
Well, it's right over here, you can't see it.
I can't, there's something happening. Judy.
Did you guys all notice
Oh,
that?
no, it's not really there, I'm not blind that way.
No, it's not there. You did all get the financials? Okay, so they were very late, sorry, very late. Year-to-date, Goose Lake has lost $91,000. Again, kind of a lot close to last year, so we're a little ahead of last year, but we realize we're still in need of providers at Goose Lake in order to make this work. Balance sheet, no real change, except again, debt to the hospital grows at Goose Lake. Okay, and DME. DME had a pretty good month. Their revenue was, year-to-date is $63,000, which is a little bit ahead of where they projected. Their costs are way ahead of where they projected. So we still are about $36,000 in greater loss than we had projected, but we still continue to see good growth in monthly sales.
So what is the other revenue of $1? Is that really what that is?
Yeah, and I don't know, that's kind of a placeholder. I should have deleted it before I took it out of here. I think it's just,
Actually, it's 60 cents.
Oh,
yeah,
really? Other revenue, what?
it's important.
Yeah.
Sorry, I should have deleted it.
Probably interest income,
Yeah, yeah, maybe,
absolutely.
on their bank account.
Mhm.
It probably is.
That's about the only thing it could be, isn't
Yeah.
it?
Mhm.
Okay. Any other questions? And we keep investing in more equipment to sell, which is good.
On the medical supply, I noticed the employee benefits, we think we were not gonna pay any, and we did. The projection is not to have employee benefits.
No, we would not have projected that. I think that we might have separated it out differently. So Joey is trying to kind of expand the way that we're doing this bookkeeping. For next year, we'll have like a more detailed, probably income and expense. So we're trying to improve it. And I think sometimes we just put salaries and wages all together. But we've got we have like 1.5 more people than what he had originally budgeted to employ.
Any other questions? Charlie, you want to talk about Goose Lake or Lakeview Gardens?
Yes, Larry and I can talk a little bit about that. We have a couple things that are going on. We have a final projected date when we believe Detroit will finish the project.
This year.
The good news is that we're getting closer. The punch lists are scheduled for, we have several in May, and then that's for building A and B, and then in June, first part of June. Our planned open house is now June 21st with a move-in date of June 26th. We moved it up a little bit further for a couple of reasons. Number one, with graduation being the week of June 10, we did not want to put that at conflict for anyone. And so this made the most sense. Again, we want to have the public open house at a time when we don't have any of our patients there. We would move the patients in after that.
So you said the 21st, the open house?
21st would be the open house. June 26th would be when we would move patients actually into the cottages. It was,
Which meeting? Like,
What time of day will that be, Charlie?
Larry, do we have an answer on that yet?
For the time of day for the open house?
Yes.
We have not decided yet, but we're thinking probably later in the evening, so then between like 3 and 6.
Oh.
So then some people, if they want to come after work, then they're able to do that.
Okay.
I'm not past Larry's bedtime.
Other than that, everything is moving along. They were pouring concrete for some of the patios this morning. We're working out bugs. Larry, do you want to add anything about?
Yeah, they poured concrete earlier this week, and the colored concrete that is a shared patio for A and B it looks really great.
Colors?
Yeah.
Oh, really? Really?
Is
And
it plural or just one color?
one color. Sorry, it's one color for the shared
Not
patio.
each cottage having a different color.
No.
Okay.
I believe building C is going to have a different color, is that correct?
It's the same color.
Oh, it's the same color. Okay.
Let me know when you're gonna pour so I can put my handprint in.
We'll be sure to do that next time.
We might leave you in there.
The buildings look wonderful. Really excited for the punch list to get completed. I really don't have too much more to add, unless you guys have any questions about the project.
Just move in.
I think we've told you a lot about what was going on at our planning session 2 weeks ago, so it's hard to, I don't want to keep reiterating things. So if you have any other questions, I'd be happy to answer.
Okay, we'll move on to the clinic remodel update.
I sent out to you information about the changes that Detroit has had between the 50% drawings and the 100% drawings. So the first estimates that we got from them, and Jason and Mike can talk about that, but if you recall, they originally, when we were selecting them to help do a design build, the idea was to have them involved, to help make adjustments and design changes as we go. So then they came back with an estimate based on 50% of the drawings. Now it's 100%, although 100% isn't exactly 100%. There are still lots of things that are not defined in the drawings. And Mike and Jason can talk about that. Would you like to talk about how you came up with your estimates?
Sure.
Yeah. Okay. We have,
You get the slides.
which ones would you like first?
Let's start with the map, the colored.
That's the clinic layout top.
Correct. Yeah.
It's an Adobe.
Does this include the sprinkler system now, or is that?
The fire sprinklers?
Yeah.
Yes.
That's okay.
Yeah.
It fails.
So one of the things we, first of all, sure, yeah, great. Thanks for having us here to kind of update where we are on the budget estimates. And as Charlie mentioned, we've done a couple of budgets now. We worked off of 50% plans and provided an estimate. And then over the last several weeks, we've gotten what are called the 100% plans, or they're really not 100%, but they're pretty close. And so we've done an updated estimate. And one of the things that we noticed this week in analyzing costs is that the scope of work has changed a little bit, which is okay. You just need to be aware that part of the reason the costs are gone up is because the scope of work that's included is a little larger than the original RFP scope. In the RFP scope, this isn't color code. The color code is not showing exactly, but there were 2 new addition areas, and those have stayed the same. That's approximately 6,100 square feet. There was an extensive remodel area, Clinic 2, which was about 4,700 square feet. And then there was a soft interior remodel area. It was about 3,600 square feet in Clinic 1.
Can you remind me what a soft interior remodel is?
Well, it can mean a lot of different things. Those, I'm trying to use the words that were in the RFP scope, but to us, that would mean,
Patch paint is a pretty simple
yeah,
summary for a soft remodel.
flooring replacements, paint,
Yeah, finishes, updates, basically. If you
Yeah.
look at it as
Right.
updating finishes, you know.
not structural work. Or MEP.
Yeah, you're really just freshening up of the space.
Mike, can you explain what MEP
Oh,
means?
yeah, MEP, mechanical, electrical, plumbing. We refer to that collectively as MEP. It's a large part of a project's budget. I mean, on average, it's about half of the expense of the overall budget, so it's a significant deal. In 100% plans, what we have priced out is the 2 additional areas, 6,100 square feet, a tentative expansion area here, which is 1,200 square feet, and then a extensive remodel in Clinic 2, 4,700, extensive remodel in Clinic 1, 3,600. So Clinic 1 has become more intense work, and
So extensive, I guess, to close the whole loop on soft versus extensive, you would be looking at, you know, much more obviously intensive work. You're tearing down walls, really overhaul on the HVAC systems, electrical systems are essentially completely removed and being replaced at that point. So.
yeah.
One of the reasons why Clinic 1 had more extensive remodeling is the addition of Dr. Skrinsky. And so how he reformed some of the space to more accommodate the kinds of services that should be delivered. It still is the specialty clinic, it still has lots of specialists coming, but because of the numbers of patients and how that process in patient care works, that's how that change came more about.
It doesn't show any difference in the wall structures between the 2 phases.
Doesn't look different.
This drawing is actually out of current set. It's just a mirror image of the same plan side by side, but we've just marked up the colors. So
Okay.
there was, the plan on the left didn't exist at the time of the RFP. It is the same plan. We've just colored it a little bit to just sort of show you, to designate the areas of, you know. So it's,
And then 100% includes an HVAC system upgrade in Clinic 3. So those are the major components. There's also, it's not shown here, but there's a parking lot that'll be out here, and there's some sidewalks, site work, and there's a sewer that runs about across, runs along the line about like that. It gets a new lining. It's an old 8-inch clay sewer. So a couple of other things that got identified as the plans get more and more developed. So
We did not know at the time that there was a sewer running under the buildings.
So do you just insert a liner or something?
yeah, there's only a few companies that do this in the West, but they go in through a manhole, and then they've got some kind of special equipment that goes down the 8-inch pipe, and it pulls a liner with it, and it gets out upstream at another manhole.
Wow.
So what that will do, it doesn't improve the structure of the old clay sewer, but it does make it more watertight, I guess, more enclosed.
More stable?
Yeah, more stable. Then,
And the HVAC in the upper building there? you added?
Yeah, this one's getting a new HVAC system. And then this hallway here gets some soft interior remodel. We get some new acoustic ceiling, and there'll be some touch-up painting and some transition work between the new and the existing.
So how this translates to numbers then, obviously, you can see where, from the standpoint of the starting point, you know, at about 4.5 million is where we saw this thing to start out at. You know, certainly a strong portion of why you see the number of, you know, where it's at today. You know, it obviously comes right just simply from the fact that the scope of work is much bigger. You know, you're not paying more for the same project. You're just paying for more of the project at this point if it were to proceed as currently designed.
Right.
So
what we did is we put together we envisioned the project under the RFP scenario. I know the original budget was $4 million, but when we kind of first started looking at this, without a lot of analysis, but just some overall numbers, we kind of looked at 3,600 square foot of light remodel at $100 a square foot, 4,700 square foot of intensive remodel at $300 a square foot, and then the new addition space is 6,200 square feet at $370 a square foot. So we kind of saw the overall project with some contingency, maybe needing a budget of around $4.5 million at the RFP stage.
And maybe just to be clear on this too, at that point, the level of information that we've got is essentially narrative type of information. Right. Written paragraph form, virtually no details. So the plan that you see, you know, that you asked about, hey, it looks like the same floor plan, that information isn't available at the point that, you know, we're making that pass. And those numbers are basically put together, you know, reading that narrative and saying, okay, we're looking at clinical type of spaces, and looking at our past cost history off of similar type of work. And certainly then you're looking at that, you're trying to apply your best, past experience with that kind of work to what you're envisioning here off of just essentially a verbal description at that point. And that's not untypical, that's the way that starts at that point. So, certainly then developing here now to where we've certainly got much more information, to work with now at this point. And that then generates the numbers on the right side of what we're calling 100% scope.
Yeah, so this is 100% scope numbers in a real overall summary form that totals to the same bottom line as the more detailed information that Charlie had sent out to the board. What we have at this stage is a set of plans that are probably 90% complete. We don't have specifications, but there's a lot of notes on the plans. We can get pretty good idea of the cost at this stage, and we have quotes from mechanical, electrical, plumbing, fire protection subcontractors that are working for us at the Lakeland Gardens project. We have quotes from other subcontractors working for us at the project. So we're probably about 75, maybe 80% covered by quotes. They aren't big, but they're budget estimates. So it's much more than just they think it's worth this much a square foot at this point in time. Our general conditions are broken out separate, which over here they really weren't. This number, obviously you would have general conditions here, they're just sort of covered in these numbers. But now we show the $512 of general conditions, $793,000 for the clinic one. That's gone from light remodel to extensive remodel. You can see price per square foot in Clinic 1 and Clinic 2 are virtually the same. We're in the $200 square foot range. Clinic 3 is just HVAC upgrades, so this isn't really that price per square foot isn't really a meaningful number. Clinic 4 and a common reception area, these are the new additions, and you see that's about $300 a square foot. Same as the hallway expansion area, that's totally new construction. And then the value of the site work, the parking lot, utilities, site concrete, landscaping is about $269,000. So that gets to estimated costs of $4.8 billion, and then we add bond insurance and fee, which we have to do. And here we've got the contingency reduced from 10% to 5%. We know more about the job, and we're at the 5.4 million number. If we wanted to just real quickly compare this number to that one based on the same amount of work, we would take out this 340,000 there, take out that 160,000, that's $500,000, and then let's say we just cut that in half. So you take out 950,000, almost $1 million to compare this scope with that scope, and now you're down at $4.5 million again.
And this includes replacing all the tile roofing?
It includes replacing all the roofing except for Clinic 3. Clinic 3 already has a composition roof, so we aren't doing anything there other than that little hallway transition that is right where the new common reception area enters, sort of an over roof framing that happens there.
And I noticed that some of your big jumps in your estimate were plumbing and electrical.
Those are the two biggest
Right.
jumps, yes.
Is there any hope that that would be less when you bid it?
Yeah, I think that the answer I would say is yes and probably not. So when it comes to plumbing, I would say certainly the hope is that, yeah, we see some improvement. It's certainly a trade. We identify as well that, at this point, we're just working off a budget with no specifications, for the project at this point. And that's the case for all the trades, but, certainly there's a lot of specified element type of stuff that gets, written into that. Some of the things that have gone with those numbers when you're talking about the jump in that is that some of the lessons learned with some of the geothermal stuff and some of the new requirements being put on geothermal systems in the way of metering and everything else are now built into the new 100% scope project that really have been learned through the process that really nobody knew about at the original RFP time. The geothermal system has obviously been introduced from the time of the RFP when we're looking at past costs, and considering more conventional systems, if you will. So the upfront costs on those geothermal systems are typically more, but certainly over time the payoff for you, it's probably to your benefit that you see that return on that investment come back a lot sooner, and your long-term operating expense should be better managed that way. The hope is certainly to go out and get some more competitive pricing than what we've received at this point, which again is just budgetary. It's a service that these guys are providing basically, and see that come down. Talking with the plumber that budgeted for us today, it's a very conservative approach to it. He says, I'm confident that I'm covered on everything that I can think of that this project is going to encompass. To me, that's very conservative, and we've got some ability to then work through the details. And as we get a specification written here, to really obviously focus on that trade in particular. Electrical, I think, will be a little bit tougher. And just, one of the primary reasons for that, I only speculate when I hear your temp labor costs and stuff, as I'm hearing the financial report and some of the battles that we're probably both facing, and that is on just the shortage of labor right now. And in our industry, it's extreme. And electrical contractors are probably the worst of all the trades that we're seeing. The data centers and the Amazon data centers, the Apple data centers, all these things, the Google centers that are being built right now, you know, across the state of the Pacific Northwest, have essentially just sucked every electrician out there in the marketplace, in the labor force, into those projects. And it's put really a lot of our local electricians here where they're not certain even about their ability to get labor. And these are union contractors that are obviously calling the hall, so it's not just, you know, and we're non-union shops, so we see, you know, we see both on all of our projects throughout the trades. But electrical is a really tough trade right now. And I'm not certain where the end is on that, or, you know, frankly on the industry where, you know, right now, you know, everybody's taxed from the labor crunch and the amount of work that's out there. So, you know, it's definitely one of the keys. It's definitely one of the things that we've got going into. We have a few options that we're going to be out pursuing. The electrician that has worked on this is a very good medical electrical contractor, Pacific Electric. I'd be hopeful that when we do put it out for bid, and we'll certainly be soliciting, you know, electrical quotes. To be perfectly honest, I'm not over optimistic about seeing a real influx of new electricians to the mix. Plumbing, certainly there are some better options that way. I think that, you know, where we stand a better chance of seeing, you know, a competitive field that way. The real key is going to be on, again, trying to make the process of bidding work right now as easy and as accessible to subcontractors. Because when you've got a lot of work out there in the marketplace, you go to the ones that are the least amount of work to put proposals together, right? So that's something that we're really focused on right now. We're meeting with the design team here on Monday just to talk about those last details that we need to see in these documents to make this next stage of, you know, formal bidding really be executed to the best of, you know, anybody's ability. Beyond that, we are subject to the marketplace a little bit right now, and I wish I had, you know, could be more optimistic, if you will, about some of those things, but I'd rather come in today and say, be a little on the pessimistic side in some respects, and not, you know, be overconfident that way, but definitely have some work to do on those two trades, and some avenues to go about, you know, improving that. That's a long answer perhaps to a short question.
What are we doing to the HVAC in the third building? That's our newest building, I think.
Yeah, I think what the system is there is it's mostly mechanical, and there's some associated electrical with it, but it's replacing the air handling units. It's all working in the attic space. There's some new ducting.
Is it what we got is outdated, or?
I don't know if it's outdated or doesn't work with the geothermal, might be what it is. I don't know how essential it is to do that.
We'll find out more
Yeah.
next week.
Another thing is the timeline. I know it's been tough on the cottages here. We've been over, you know, the timeline a couple of different times. So
Yeah.
do you have a better estimate for a timeline on this, or?
Well, we're going to be faced with a lot of the same conditions. We have, there's two things that happened to us at Lakeview Gardens. In particular, one was our framing subcontractor could not staff the job adequately, and came out of Reading. And so we supplemented him with people, but he finished about 8 weeks behind. And that was very tough to ever gain any ground back, because when he did finish, Then we lost another 2 weeks waiting for a weather window to get the last building roofed. So we effectively lost about 10 weeks due to framing. And then we have used an electrical subcontractor there that's a good contractor, but he's small. He was significantly less expensive than the next guy, but he is also struggling to staff the job. He's had 3 or 4 guys. He used to have 6, but 2 of them got stolen away to a big job for a client. So he's struggled to keep up, and he's probably cost us a little more time. He's sort of controlling our schedule right now as we try to finish things up, getting the electrical work done. So it kind of relates back to something that Chuck was saying, we have to be careful in the other options that we choose, because sometimes we can find a guy that's less expensive, but it's going to take longer, and that imposes another cost on the project.
It's something that, and I know the only project that matters is the one that's going on right here.
Yeah.
And I can just tell you that it's been a real challenge, in the industry here these past few years. I mean, what we could build in 6 months seems to take 8. Right now it just is you just don't see the influx of people coming into the trades that are skilled, that really are able to turn work out. So you're doing more with less, and at the same time the days don't get longer, the weeks don't get any longer. You're doing everything that you can with the resources that are out there. And I know even within our own company, and Mike touched on a little bit, we even supplemented them with our own staff to keep the guy, able to finish. And, in some cases, years ago, if you ran into situations like this, you would have said, all right, we're going to get somebody different. And those guys aren't there. They're just not out there. I mean, so, and perhaps you've heard this before, but when, the recession hit, it took so many guys out of business, and they've moved on to other things. They've figured out how to make a living outside of construction, and they just haven't come back yet. I'm not certain that they will. A lot of the, for a while we had a plumber that, was a commercial plumber, had, grew up in the business, been doing plumbing work for all of his life, 2nd generation plumber. For a while there, he bid 48 projects before he got one. Depletes all of his savings, that you build up in his business along the way, and then at that point, you just desire, what's the point of even coming back? And now he's just basically living on, closes his business, and he has rental incomes off of the rentals that he developed off of his side work. And you see that just throughout the industry. Hopefully these guys start coming back a little bit. I can tell you within our company, we advertise for guys from Portland, Sacramento, and you just don't see people coming in. The marijuana industry has been also a big influence on that. People that are able to go out and make $25 or $30 cash an hour. It's a lot easier to make that kind of money than it is doing what we do.
The 1,200 foot addition that we figured on there, how much of that is dollar wise? If you took that out, how much?
That's the 300.
That's Chuck, that's just 342,600.
Oh, okay. All way expansion.
I think if I, certainly, we could be happy to answer all questions all night long. Just maybe, I think the place where, at least from our perspective, we see where we're at, is to see some of the things to reflect on where the project started at here, at the beginning, where the standpoint of design is at now, the numbers that we see, and are we on the right kind of course of direction? I realize that overall the number is higher than where it originally was hoped to be. The project is also bigger than what perhaps was anticipated in the beginning. I think when we deal with the two trades that you pointed out electrically, other than that, we've held pretty closely to where, we started from where we're at now, with the exception of a couple of those anomalies there. So certainly that's on our end to go, put some detailed attention to that. But I think Charlie, if I may, just, the speculation that we probably look at taking out the hallway expansion. These would be good things, at this point to probably make some decisions on, to see where it needs to go that way, so that as we package up really the design team, and it's really a CMGC project where the design team isn't under our contract at all, but it would be at this point that we would want to package up sort of a final set of bid documents with specifications and incorporate what's going to be in and what's going to be out. And we can certainly look at these things. Recommendation might be to show the hallway expansion and carry it as an additive alternate. Do something like that we could, consider pricing it out, but be able to, be able to, secure some hard pricing on it, and then look at that as still sort of a continued option. The other question would be is 4 million really the number that this has got to get back to? That's perhaps some more dynamic changes, perhaps abandoning the geothermal idea. But at this point, that's a complete, redesign of what's been done.
In the upfront cost, how much is the geothermal at, do you know?
I couldn't tell you exactly with a pinpoint, on that.
Yeah, I don't know.
I'd say that you're probably, in the neighborhood of 20% or so, maybe, to a standard, just conventional split system, but I'd hesitate to, bet a paycheck on that, if that's right.
We can come pretty close,
but
because we did get some estimates both from Darrell as well as from, I think it was Arcsign that did the design. We brought that to you before.
Right,
but
I remember that was.
But that was based on what they thought the cost estimates would be. Detroit came better after talking to the plumbers.
Right.
With a little bit more accurate information. So what we had talked about before the meeting was if we pull out the hallway expansion, if we reassess the Clinic 3 HVAC and look at where else we could refocus, that we could get a number closer to what our estimate was, that might make sense.
See, Charlie, I look at that Clinic 1, and of course that's more than double, but and I'm not sure if there's anything can be done with what you're trying to accomplish there. I mean, 360,000 seems like a huge amount trying to orthopedic.
So part of it is we need to have a little bit more information. And so now that we have a much more accurate information of where Detroit thinks the construction will be, we need to go back and figure out how to get much closer. But we just got this, we want to give the information to you as quickly as we can, so you see where it's at.
I want to break down Don's timeline question just a little differently and ask how quickly we would get to the point from here to when we break ground and get going.
Yeah, I would say that, I'll have a better idea, I think, on that when we meet with the design team on Monday, because their work, and let's just, for scenario's sake, say that, proceed, okay, with the scope as we're talking about right now. The next stages are basically to finalize the bid documents. And so that's what we'll be sitting down Monday with the design team and plugging that out. But I'm figuring that there's probably 2 to 3 weeks, Mike, to finalize a set of documents to where it effectively then at that point can hit the street. And I know there's certainly some wanting to get this thing going.
The weather's breaking.
Now's the time to do it without no question. So I would like to think then that, if we're, let's just say by the 1st of June, we're out on the street for, hitting the street for bid, and give it at least 3 weeks out there in the advertising so that you get that, and hopefully those plumbers have enough time to look at it. Maybe, I said maybe ready around by just 1st of July as kind of a ballpark, but I think that if we, certainly sitting down Monday with the design team to see if there isn't even a little bit quicker plan to that, but does that might be your
Yeah, I think-
details on that?
I was thinking the earliest, pull everything together, bids come in the way we expect, right after the 4th of July. would be time to break around.
Help me again with the length of the project.
I've got general conditions in there for a 12-month project right now. This has to be done sequentially. Can we go back to, Jim, go back to that? The way this is thought to occur is that the additions would be done first, and then these folks move into this new addition, and then this renovation happens. These folks move in there, and this renovation happens. Not sure exactly when that fits in, but it's kind of fits in.
If you recall, at the planning session, we talked about some alternatives to how we might handle Clinic 1. And so that might help in the staging process. So we still have more conversation to move on this. Because we think we might be able to, there might be some things we can do with Clinic 1 that we didn't anticipate in the past. So we might be able to sort through that.
Part of the way this would move is, we wouldn't just finish this and then start into that. There'd be some, how long would there be some move period that you'd lose in between each one of those phases?
Right. Well, thank you for coming over.
Yeah.
Appreciate the chance to present it.
Thank you, guys.
Yeah, we should do that.
Okay.
Any board members have any other questions before we move on?
The only other question I had is, I know early on in the other project, there was some concern about building inspectors being here timely, holding up the process. I haven't heard any indication of that at all. So has that been very cooperative?
I think they've worked with us really well. I'm not aware of any delays due to inspections.
We've had really good relations, so it's going well.
I would just say too, our relationship here in Lakeview's been great. Our guys have, as much as you can enjoy the Lakeview winter, they've appreciated the work.
They don't like roofing in the
There's
snow.
There's a lot of work out there, but they've done it, and the concrete work certainly is.
Although the framer did not.
The framer didn't enjoy this much, but and those are the things though where we've jumped in. We sent our guys over to dig snow out. Certainly made every effort to minimize what has just been absolutely brutal winter.
I have to say that Jim Weber has been a real asset.
Jim's been a good, patient guy, and I appreciate that. So.
We know we'll be scraping the bottom of the barrel when you're out there with a hammer.
I'm just telling you, if it comes to that, you better find somebody else, because you're in big trouble if it comes to that.
Or electrical, can you be an electrician?
What's that?
Can you be an electrician?
Oh, my goodness, yeah. Boy, I'll tell you, it's,
For trade work, that is.
yeah, it's definitely the way to go. There's certainly a good living for young people or anybody that wants to get into the trades that, I think a lot of doctors right now would probably tell you to go be an electrician, right? So, anyway, well, thanks for having us.
Thank you.
Charlie, do you want to tell us about Hunter Communications?
Yes, I believe I've sent out to you the latest. It's really hard to read. I don't know why they can't seem to get it larger. What we did was, Gerald, we tried to focus on, one of the things you asked at the last board meeting was that we have a not to exceed number. And Dave came up with better language. That what they did is they actually took the language that Dave suggested, was that It does not have not to exceed number. It has a description that we don't, we will not be responsible for construction unless later agreed to in writing. So it doesn't, what it does is it gets us an application and gets Hunter in the game. And they really are anxious to try and see if we will get this.
Now, as I read this, Charlie, we've committed that if they do it right, then we'll pay up to $1,500 a month.
We would use their
4 years.
service. If this gets approved by USAC, gets funded and gets built, we would use their service. Yes, that's correct. We use them for the hospital right now.
So this would be on top of what we currently pay.
No, what we would do is, we have a contract with a company in California. It's an AT&T company, not a Hunter company, so it's different vendor. We would cancel that relationship and do this, but we would have the higher speed internet. We have 3 T1s there now. This would give us 100 megabits a second, so significantly different broadband capability. And it would be greatly enhancing the value, or the loop, if you will, for the community. That's really the greatest advantage this would offer. It's not a complete loop, but it's very close. This would not happen overnight, trust me. Because they'd have to lay the fiber.
Okay, thank you.
So if it's all right, I'm going to enter into this agreement. Okay? Thank you.
Board Education, Caravan Health.
Okay. I don't want to talk too long, but a little bit about,
Charlie, the
but
PowerPoint?
let's start out with PowerPoint, yes.
Again.
Oh.
Okay, so let me talk while she's teeing up this slideshow. I've talked a little bit in the past about the National Rural ACO. You may recall. So an ACO stands for Accountable Care Organization. And with the Affordable Care Act, or that which got sort of started through tonight with the repeal, but in the Affordable Care Act, it calls for the establishment of accountable care organizations. Oregon created what are called CCOs, or Coordinated Care Organizations. That model, the CCO, is primarily, almost exclusively, for the Medicaid population. There are some other components, some commercial insurance, and some other parts that get fit into the CCO, but it's almost exclusively a Medicaid population. On a national level, the ACO is predominantly, or accountable care organizations, are predominantly Medicare patients. Typically, in order to have an ACO, to have a Medicare risk population, so this is risk being where you contract with the federal government to be at risk for the amount of care that's delivered to a set population. You need to have a population of at least 5,000 seniors to have the risk be manageable. If it's lower than that, you can have catastrophic events. Some portion of the population becomes quite sick, or a lot of it is has higher sickness, and therefore you lose money. That's what happens with some of these exchanges, where they have a higher percentage of sicker patients, and then that causes too many claims and all that. So, in order to get the 5,000 population of seniors, not just population, seniors, it almost exclusively, these ACOs have been in urban settings. In order to try and accommodate the rural population, a entrepreneurial gal, her name is Lynn Barr, came from Truckee Forest Hospital it's Tahoe Forest Hospital in Truckee, got together a group of hospitals and said, and went to Medicare and said, what if we instead, because small hospitals, rural hospitals can't get that population, what if we linked up several hospitals together and their communities, and we formed enough population to get 5,000 members? Would you be willing to let us take on risk and manage this population? And Medicare said, we'll give you a trial, and gave them a bunch of money. And so they started off, they have about 23 hospitals in this one grant, or 23 ACOs with a number of hospitals within those. That grant was one specific deal. Because of its success, CMS gave her another $60 million, and she's now going after, she has hired a bunch of people, just one person, are going out, and they now have signed up 160 additional hospitals, or have expressed interest in all over the United States. So they formed a second company called Caravan Health, which is the first one, the National Rural ACO, is a nonprofit because it was a trial. Caravan Health is a very similar project, but it is a for-profit project. When you look at the number of ACOs, 23, 164 hospitals, 6,000 doctors. All these little dots are not ACOs, but she got CMS so Medicare, to approach it from several different standpoints. Could we work on the patient-centered primary care component and then also the ACO? We are participating, so if you look up in Oregon, there's a little dot, and we're one of those. We are participating with Caravan Health to help us on our patient-centered primary care component, so that we can learn more and teach our navigators or case managers, if you will, but they're navigators, to help patients maneuver the health system, especially Medicare patients. What they have found in the hospitals or the ACOs that they've worked with, they have had a significant savings, the shared savings of 257%. Now that's a lot, says a lot of percent, they've had a great deal of success. Now what's coupled, why this is becoming more and more interesting, is two programs called Macra and Mips. These are two programs that are now putting physicians, medical groups, at risk for care of the patients that they're delivering. Not just to deliver good care, but the cost of care. And so we're moving in a transition from volume to value. You've heard this talked about before. So instead of seeing lots and lots of patients, what they want to say is we want to make sure that the patients are getting value, or actually not the patients, the health system paying less. So greater value means you spend less money because you're doing more preventative things. There's a lot of talk about why you should do this, participant in the ACO. But a couple things that make a big difference. Start rules are Stark, for those of you that may not recall on Stark, one of the requirements that we have, one of the important parts that Pete Stark developed, he's the representative from California, several, 20, 30 years ago, said hospitals cannot give undue incentives to physicians to utilize their facilities. So we can't pay doctors to admit to the hospital. We can't give them free rent. That's an inducement to use the hospital. That's a violation of the Stark Amendment. When you participate in ACO, you are immune from any incentive issues. As a consequence, if we set up if we participate in this, if we encourage our physicians or encourage our patients to use our facilities or facilities that we believe are either more cost-effective or more efficient, it is not a violation to give them incentives to do that. It's important. It also allows us to access, the physicians to access the Macra offices. Now, we are working on that, but this group believes that they can do significantly better on an average. And they have studies to show that those that have participated in their group go from, and they have a patient-centered primary care home, which again is that great incentive to focus on preventative care. Lots and lots of early work to keep the costs down. They've proven that patient-centered primary care homes that are not participate in an ACO go from 20% utilization of those preventative services to an excess of 50%. If you are in excess of 50%, you get significantly bigger bonuses. And Medicare is trying to do that. What's interesting about this proposal is there isn't downside risk. It is only upside risk. Why they're extending it to rural is to try and get us into the model of being more focused on care that's delivered outside our community, because that's really where the bigger costs are. This has been going on for, they've had this group going for about 4 years. 3 years of good data, they're ramping it up further and further. Many people ask, is this going to go away? With the policy that was approved today, is it really going to go through? Is it going to throw this all out? Most people believe in the industry that the incentives and some of the concepts are not going to change. That employers are asking for this, that Medicare is certainly seeing a benefit from it, and that it's something we ought to think about. So we have no obligation to do this. We have an opportunity. This is some of the benefits of the MIPS and the Macra. There's all sorts of criteria that you have to focus on. This is their sales pitch, so I'm not trying to, they provided me with these slides. All different kinds of quality tools, and you can see the different, I mean, it's all sorts of acronyms. It's very complicated, and they like it that way. Their idea is they teach us, and they teach our physicians, and they teach our processors to get much, much better at how do we track the care of our patients. Probably the biggest part about what this does, if we were to participate, is it would start giving us a slew of data. I provided you with some information that we paid Kaufman Hall to get for our market. This would give us direct, current information every month of what our patient population is doing, the Medicare population. So it's much more real time. They have all sorts of reasons why it's so much better using their kind of support services. If you don't start focusing on this, there's going to be penalties. The reality is a critical access hospital is not at risk for this, but that doesn't mean we don't have the opportunity, if we do have savings, to enjoy the benefit. Okay? Lovely.
Yeah.
That's very clear.
But what I wanted to do is, I have one more set of slides that, they go through all this calculation, and it's a very convoluted process. But if we were to participate, and right now, we are accessing we're accessing the 24-hour nurse hotline. We are getting some training. So what let's go to pull up the tool. Okay.
The next one.
Right. So this, how they are estimating what our costs and what our potential benefit could be. So if we were to look at the Macra benefits, this is that hard to read screen. But if we take in our community and said, how many family practice physicians? Now, nurse practitioners, unfortunately, aren't included in the Macra calculations. Although, if what it allows a physician to do is to see far more patients, because the extender is extending their population that they can manage. The way the rules were written, I didn't create them. So what they're saying is we have 6 physicians. This includes our Alturas clinic, okay? We don't have all these other specialties. That's what you saw in. When I put in nurse practitioner, you can see it doesn't have a huge economic impact for us. Sorry, Lisa, I didn't make it up. That has some impact with Dr. Skrinsky on the patients that she sees, and the general surgeon. I don't know if I put general surgery in this model. I didn't, so I could put, oops, not 7. What did we do? Back it up. Did I hit it right?
No, you just took it out. You're already on it. You wanted to put a 7 in there?
Here we go. Right
There you go.
Just hit
Gotcha.
One.
Yep.
Okay, so by using this calculator, if we then go to the ACA calculation, there's a lot of assumptions. This is a marketing tool, so it's not perfect. What they're assuming is that every primary care physician takes care of 150 seniors. On a national average, some take on more, some take on less. But if you use the number 150, that would come up to about 900 Medicare patients. Clearly not the 5,000. So we would participate with 2, 3 other hospitals, maybe 4. They try to make it similar locations, similar environment, if at all possible. What they're saying is those that are in a patient-centered primary care home, if they focus on population health, it's not pop health, population health, they think they can move the dial, said, from 20% to 50%. I said, I think we're doing better than 20%. They said, fine, change your number. You can make it, instead of 20%, you could make it 30%. And it'll drop down the profitability. But over a 3-year time period, that is what the potential Macra bonus would be for physician services. Some startup costs. The cost to get into this, it's not $5,000, it's actually $10,000. And then we would pay $5 per member per month. If you take 900 members times 5 per month, that's how you come up to that calculation. And what it says is, if we were to do this, potential new revenue, which is by encouraging seniors to come in for preventative care and for doing other kinds of managing their care, we could generate an additional $1.7 million. Startup costs for all this, they're estimating at, I don't know how we come up with that number, but the ACO startup, it's actually, and I'll tell you why there's a $5,000 difference. Their fee is $160,000, which is that $5 per member per month for the 900 members. They're saying we would net out $1,032,000, excuse me, if we were to participate.
And this is without adding any staff, any doctors, any nurses?
That's correct. That's on what we are doing right now.
We net out.
An increase, yes. I tried to get a slide that had what their experience has been. And what they're saying is, we could do all this focus on the population health revenue. And when we look at population health revenue, I know this is hard to read. I don't want to carry on too long, but psychiatric care management, follow-up psychiatric care, preventative screenings, all the possible screenings that we could be doing. Those are the colorectal screenings, those are the psychiatric or mental health or depression screenings, all those things. Now, we're doing this with our CCO. We're actively working on this. So I don't think that we say 20% or 30%. I don't know exactly what our numbers are, but we can prove it. We can, Juanita, through the eClinical Works, could tell us. Possibly Dr. Graham and Lisa could tell us how they're doing in their clinic. What they're saying is they would prove to us what we were doing based on the claims, and that's what it's based on.
This is clinic care, not hospital care?
This is clinic care.
Okay.
Yes.
And that's
Yes.
revenue, $1 million net revenue.
That's what they're saying. I have not gone through all the details. So the reason why I'm bringing it up now is in order to participate, the normal process is you would sign up before the 1st of May as a possibility. So I signed we're interested. By June 30, you would pay the $10,000 to participate. It would not begin until January 1, 2018. And that would begin this 3-year cycle, okay? The reason why there's the $5,000 or $10,000, I keep saying it's the difference, is CPSI said, we think this is a good idea. And there's hardly a lot of hospitals that can't afford the $10,000 and the $5 per member per month. So what we're willing to do is we'll pay half the startup cost, and we'll pay half of the per member per month amount. In exchange, we'll take 10% of the cost savings, of the shared savings rather. That number right here. They're confident because of their system. They'll be able to track it, they'll be able to help. And they're putting money up, and they're saying for us to participate, we'd be willing to, we'll take 10% of that, but we'll put up the money. I personally think if we were to think about this, it would be worth doing to pay it ourselves and not give them 10% of the cost savings. Because I think our physicians, our systems are good enough that we would enjoy, I don't know if we'd enjoy that much savings. I don't know. But it would certainly be a bunch.
It's about either way. If they took half of the 162,000, is that what you're saying? And 5,000.
And 10% of this, yeah. And the 5,000.
And the 5,000.
And this revenue goes back to the physicians.
Goes into the clinic.
Goes in.
Now, if we were to say, let's set up incentive measures to the physicians and said, here's the goal marker. Here are the steps that it takes. We want to give you incentives. If you'll do those things to help us get there, we'll share the savings with you.
How much more work is it for the physicians and the nurses and the staff?
It is more work for the staff to get a lot of it geared up, because a lot of this is done by the medical assistants. There is still work that the physicians have to do, no question about it. But if we can set up the systems so that the MAs or other people are doing the callbacks. Somebody made a comment about how our eClinical Work sends out reminders of things. If we can have automatic calling, we can set up systems to support the practitioners seeing those patients.
Have you had a chance to pass this by the medical staff?
I've not.
You do intend to do that?
Oh, absolutely, absolutely. Number one, I wanted to see if you had any interest in this. There really isn't a lot of commitment, but it's an opportunity. I've been watching this over the last 3 years, 4 years, and seeing how the other hospitals are doing it. They keep showing that, and again, this is their marketing material. Not all of them are winning. Some are not doing what is happening is some of the bonuses are based on your cost. So if you can, say, have patients not seen in your emergency room, that reduces the cost overall to the system, but it increases the cost in clinics. And Medicare takes a 3-year average cost. So when they look at the benefits. So it's a very convoluted process. But we're already doing this for our Medicare patients, our Medicaid patients. So if we can ramp that process up and get some financial benefit of it, we did get rewarded money from the CCO the last couple of years for the work that we've done.
Now, as a practical matter, because it's Medicare and we get paid 101%, really financially probably doesn't make any difference to us, does it?
This is extra money on top of it, and that's not including the cost rate. And to top things off, what they're claiming, we have not verified this with Whitley, but what they're saying is the costs here, 162, because this is all delivered for Medicare patients, that comes off 100% off our rural health care, the RHC, Rural Health Clinic, cost rate. So
It does have an advantage.
it does have an advantage, yes.
Well, we'd be foolish not to look into it, but make sure that our physicians and nurses are on board.
I understand, I understand.
Do we have enough seniors in, do we have 900 seniors in the county? We probably do, don't we, that are cared for here?
We believe we do. And that also includes the practitioners in Alturas.
Our total population, as I recall from the report we had, was 8,000, so I'm sure we've got 900 seniors.
I would think we do.
25%.
Would be my guess. So, and again, what they're trying to say is, you could do it all yourself. You don't need to pay us that $160,000 a year. You can do it yourself. And this is the kind of estimated return on population health investment. So if we keep doing what we're doing, if we think we're good enough, that's what we think we could hit. What they're claiming is, we're going to hit you a whole lot better. If you do nothing, you can see that the cost investment is not very little, and that revenue, it's not much different than if you do it yourself. Their claim is you're going to double. And that's been their experience with those that they've worked with.
I read somewhere in there that they give you a 14% advantage because you have electronic health records.
I mean, it's a convoluted process. It's not easy to describe. But the bottom line is what this does is it captures what we're doing for our Medicaid population and pushes it to Medicare population. That's really what it says.
And they probably are better, patients are better taken care of, better now.
That's what the studies show. So
That's
we
what
would
they're trying to do.
assume, pardon me?
They're trying to get them into the clinic and out of the ERs.
That's exactly right. They're trying to do, if we can find problems early on, the cost to fix them is significantly lower than if you wait. And that's fun.
Great.
Any other questions? I will pursue, talk with the medical staff about this, but I wanted you to get an idea.
Charlie, have you talked to anyone that is participating in the program and get feedback? Hospitals?
I haven't directly, there's a couple of guys that I know that are participating in it. I have talked many times with Lynn Barr, the founder of all this. And she's, of course, she's a zealot when it comes to this. And she firmly believes that this is making a huge difference for rural health. And she's an absolute advocate that we can deliver more cost-effective care in rural settings than you can in urban settings. And she keeps saying I can prove it. So,
It would be interesting, however, to get some feedback from some rural hospital that's involved in this.
I will have that. Thank you.
All right, Teresa.
I just have 2 or 3 things I wanted to mention. First of all, over the past several months, we've been working together as a committee, working on the startup of the orthopedic surgery program and joint replacements at Lake District Hospital. So as you may or may not know, our first patient is scheduled for this month on the 23rd. So we are looking forward to having all of our equipment actually arrive tomorrow or Monday. So the last of all of that will come in. And we think that we're coming along nicely. Some really good things have come out of this in terms of the effects of, and this always happens when you upgrade to prepare for a new program, it affects other programs in a positive way. So other things are happening that will affect other types of surgery as well as other areas, clinical areas. So that's really good, and we're very excited about it. So looking forward to that. We have had a change in the last month in our CPR program, so we've kind of upgraded that, and we actually have a part-time person who's heading that up now, and I'm looking forward to that expansion. So her job is to provide a lot more CPR courses for our community as well as for our staff, and some of those will be offered as a community benefit to any people who act as volunteers within our community or work for volunteer organizations. And then we do have a number of businesses who we will still charge to provide CPR for them. But it's really, there's a giant demand in our area that has not been met. So I think she's very excited about that. Her name is Brian Pochop. She worked formerly in the clinic, so she's working hard at getting this up and running. It's a little bit of a slow start, but I think we're getting there. And the bad news, I guess, I left the bad news for last, but we do have a number of changes in acute as well as several more medical leaves happening, so there will be some more temporary labor costs coming up. Probably some of the highest numbers of temp labor that I've seen ever. I'm going to be using 2 of them are for CNAs because I absolutely cannot even hire CNAs. So it's unfortunate, but it's happening. So that's my report, unless any of you have questions for me.
Larry, get us some CNAs.
Working on it. Our turnout for our CNA classes that we're providing have been not what we were expecting. So that's hurting us pretty good. We have another class starting up, I believe, the middle of this month. So we're hoping to have a good turnout on that.
Do you have applicants for that?
I believe we have 2 that have turned them in so far.
Do you want to sit down on scholarship interviews?
We weren't so successful last time, were we?
I believe we had 4 people receive the scholarship last time.
Oh, good. Okay.
Did they complete?
2 of them are working on passing their boards. We scheduled that today with headmaster so then they can take their exams.
Okay.
I don't know what the exact date is for that yet.
Thank you. Thank you, Teresa. Employee recognition.
It's always a great chance to recognize somebody who's made a great contribution. This person has been here a relatively short time, but has just really taken off and made exceptional changes that really impact our organization. And probably the most exciting is the most recent lean program that we started, that we did here a couple of weeks ago. That was the program we got the grant for with 3 other hospitals. The person that ran that and has been doing such a great job is Namrata Dunn, or Nam Dunn. So she is our employee. As I move into that, I'm going to tell you about a couple things that she's been involved in helping us. She had a big impact on, of course, in acute, and helped to set up some processes that really have supported nurses and have supported Teresa. We were selected to participate in a program put on by Care Oregon called Live Well. And this is a program that is focused on the improving the quality, satisfaction, and an experience of care in predominantly long-term care facilities. They started off with 10 communities in 2015, and they're expanding it to 40 communities because of its success. We were selected as one of them. Larry's going to be very involved as well as the staff. And it really focuses on the staff of the long-term care cottages, soon to be, and now is a significant part of it. The other part, of course, was when we had the lean training here, what's called a rapid improvement event. It was involving the clinic, and they were team members that were involved spent, I believe, 2.5 days in very intense working on issues. All of them were engaged, all of them participated, and they've got now a schedule of what they're going to do to implement these changes and improvements. Now I'm just planning on having 3, maybe 4 rapid improvements, or RIEs, throughout the rest of the year. So it's pretty exciting stuff for us. We are also going to be participating in an OHSU study that we were selected. They're going to be doing this through the School of Nursing and the Klamath Falls campus. They're going to be interviewing people in both Lake County and in Harney County. And the doctoral nurses are coming out. They have their doctorates or are working on their doctorates to do an analysis of they want to understand personal health and health care from their patient's perspective for people, older adults, that is 75 and older. And they're going to be coming to Lake County. So we've been selected to participate in that. So that's really exciting. We're going to be coordinating that through the physician's office, through the senior center, trying to get people that they could interview and get some good information on that. I sent out to you a letter for us to respond to the Lakeview disaster unit. All of you have seen that. We made one suggestion that Jane suggested that we add in there a statement saying that we will provide all of the documentation that we have received. I believe I have sent virtually everything to either Alan or Chuck Mester. But would you like me to read the letter?
I can read it if you like.
Okay, just so the public knows.
Okay. This is to the Lakeview Disaster Unit Board. Ladies and gentlemen, the relationship with Lake Health District. Over the past year, we have been talking about ways that our two organizations can work together, largely due to the need you have for a permanent home to house your staff and equipment, and the increasing difficulty you're having to find volunteers to go on runs. The service you provide to our community is vital, and one which we greatly appreciate, especially your dedication and commitment. As we look for ways that the district can support the Lakeview Disaster Unit, we continue to be willing to split the cost of an EMS coordinator. We would want to help in the definition of the job description, but would anticipate a 50-50 split of costs and duties between both organizations. The details of this position should be worked out in a timeline that works for you and would be for an initial period of 1 year. With regards to the creation of an ambulance and staff facility, the district continues to be willing to build on our property a facility that is acceptable to the unit, but we would want to enter into a lease agreement for the space to ensure there would be adequate money to pay the construction costs. Based upon the research we have done to determine how to receive payment from Medicare at the 101% of costs associated with a critical access hospital for ambulance services. All the references we have been given indicate owned and operated by the hospital is required to get the 101% payment. We would be happy to supply you with all the correspondence received. You have made it clear that an arrangement like this is not in the interest of the disaster unit, something we understand and respect. Should your position on this matter change, we would be willing to discuss how better we could work together. We look forward to continuing our combined efforts to serve the health needs of our community. Sincerely yours, Charles Kelly, Board Chair. Is that acceptable to the board?
Absolutely.
Yes.
There's one little typo here, Charlie. Okay. Okay. All right, we will send that letter out then.
Continuing on, we had a meeting with Klamath Community College this past week, talking about the RN training program and other training programs that we've had in the past. We've expressed some of our concerns. I think you've had Dr. Gutierrez talk to you a little bit about what they've been doing. You know how we have been concerned about the quality of the education that the nurses are getting, and how much they're being able to be used here. I think Dr. Gutierrez and her name is Jamie Jennings. She's I'm not sure if she's the provost or she's over this program. Understand our concerns, and they have talked about how we might come up with, they might offer us some alternatives where we would have much more say in the process. I hope to have a letter for you that promised describing the details of that. I don't have it yet, but I do believe that they're going to try to come up with a solution. We've seen some indication, even as recently as today, an indication that they want to reinvigorate some of our participation in their program. So that's a positive sign. But I'm sure that there will be some monetary involvement that they're going to request from us. Haven't seen what that is yet. We had our inspection of the lab this past couple of weeks, and it went very well. So we haven't got the final report, but we found virtually no problems. As Teresa said, we'll be doing our first joint replacement this month, so we're excited about getting our team all geared up and moving forward on that. Last thing is, I received an email notice from Gobi that our contract for mental health services has been extended for an additional 2 months. I haven't quite come up to resolving why that is. There were several things that we needed to do to adjust how the county's mental health services were functioning. I remember seeing the list. It was quite extensive. They gave us 6 months to work on all of those. We met those, but they are still concerned that we are seeing enough clients in the county. And I can't explain exactly why a 2-month extension was granted, but we still have a Gobi contract. So, do you have any questions of me? Anything I can address that I haven't?
Do we have some executive session work?
We do.
All right. We will take a 10-minute recess, and the board members and Charlie and Dave will do executive session when we get back.